Hello, and nice to be with you today. My name is Dr. Tom Rutledge, and I am speaking to you from sunny San Diego this week on the topic of a revised psychological assessment model for patients with chronic pain who are seeking spinal column stimulation or other implantable pain devices as part of their treatment options. This is a topic that is close to heart for me, as it was a process that began back in the fall of 2018 and continued all the way through today, including some of the rather serious challenges presented by the COVID pandemic. In my approximate 50 minutes with you here today, what I'd like to do is first share with you some background information about the traditional assessment role for psychologists with implantable pain device populations, identify what I feel like are some serious shortcomings in this traditional model, and then describe the new approach my team developed to resolve these problems. Finally, I'm also pleased to present some of our initial empirical findings with you from our model. And that said, let me share my slides and we will proceed. So as mentioned, I am a clinical psychologist, specifically a clinical health psychologist by training and board certified in clinical health psychology. And I've been working as a pain psychologist here at VA San Diego and UC San Diego since about 2003. So just about 2 decades now. And to provide just a little bit of background of what I do and sort of what brought me to presenting this information with you here today, that I'm a clinician researcher, and so partly I am based providing direct patient care, individuals, groups involved in assessments and treatment care delivery with patients here at VA San Diego. I'm also a research professor at UC San Diego, involved in numerous research projects involving chronic pain and chronic pain clinical trials over the years. I'm involved in a lot of administrative activities here at the hospital and the neighboring university in terms of pain management and pain policies involving pain treatment paradigms and so forth. And then lastly, and a part of my job that I very much enjoy is working with some of our junior psychologists, psychiatrists, and medical trainees in terms of providing them with good multidisciplinary training for pain management. So as highlighted, what I'd like to do in our time here today is really focus on 3 topics in some depth with you. Given that I have the luxury of 50 minutes, we can go down the rabbit hole a little bit on these subjects. The first one that I will spend the relatively least amount of time, assuming that you may already have some working familiarity with this literature, is more or less a little bit of history and information about the traditional practice of psychological evaluations among patients seeking implantable pain devices, spinal column stimulators, and related pain devices. And then secondly, examine the new model that my team has put together over these last 3 or 4 years, talking about the rationale, talking about some of the pragmatics and logistics, and then as mentioned, also some of the preliminary findings that have just become available for us here this year. And then lastly, from this 4-year quest to evolve a new and better model, what are some of the practical takeaways and recommendations? So to begin, a little bit of background. It's hard to believe that we are entering, I guess, our 4th decade in which psychologists have been more or less routinely involved in the world of implantable pain devices. This is a literature that goes back at least into the 1980s, and by the late 1990s was more or less mainstream. Some of the earliest roots began as far back as the 1950s and the 1960s with some of Milzak and Wall's research that, amongst other things, certainly supported a multidisciplinary approach to assessment and treatment for patients with chronic pain. And as technology evolved and technological interventions for chronic pain became available, this same multidisciplinary focus was still very much in vogue and endorsed. By the time I had come on board in 2003, it was an insurance mandated practice that was difficult to escape. It is seeing a psychologist at least once as part of the routine process for receiving a spinal column stimulator or perhaps a pain pump. In some ways, it's surprising that a field that was only about 10 years old at the time so rapidly evolved fairly strict and widespread mandate for psychological assessment. And it was based arguably on the factors that you see here on the current slide. One of these, especially in the early days, spinal column stimulation was both expensive, which it is remains so today, and also relatively higher risk compared to today. The devices were larger, more prone to complications, infections, the need for explants, and just sort of higher operator capabilities of being able to use these devices successfully to improve pain management quality of life over time. So there was somewhat of a higher bar at the time present for candidates. Secondly, and overlapping very much with the first point, that even early reviews of the chronic pain literature at that stage revealed that there were very high rates of comorbid psychosocial, psychiatric, and substance abuse problems in that population. And again, based on theories such as gait control and other evolving research supporting multidisciplinary models of understanding pain and the response to pain treatments, that it made a lot of sense that a psychologist or psychiatrist would be involved in evaluating candidates, considering the extent to which some of these comorbid psychiatric conditions were both present and could potentially be interfering with their ability to benefit from a pain device. Also, very early within the spinal column stimulator literature, that it was observed that outcomes varied enormously, even though there were often reported high averages in terms of pain intensity responses. It took very little searching to find people who in fact had relatively poor responses, or looking at even high rates of failed trials. So it was clear that outcomes varied, even using the best technologies. And this has continued even to today. And it was not a stretch of the imagination to consider that, at least in some of these cases, perhaps the poor outcomes were a result of some of the overlapping psychosocial or psychiatric conditions. In the traditional model, a pain anesthesiologist or other pain physician would refer a patient to a psychologist or to another mental health expert to provide a pre-stimulator, pre-implantable pain device evaluation. And amongst the mechanics of this process, the mental health assessor was usually looking for conditions that are listed on this slide. And even though most of these were not evidence-based in the sense of emerging from clinical trials as being demonstrated to predict adverse outcomes, these were clinical consensus guidelines that were arrived at by some of the leading researchers and clinicians in the field in the 1990s and survived over time. And this included really a wide panel of related, but sometimes somewhat independent psychiatric and psychosocial conditions. And some of these could be formal psychiatric conditions, such as mood disorders, personality disorders, severe cognitive impairment, and dementias. But also some of these were more behavioral. These might be, say, substance abuse conditions or involvement in lawsuits, workers' compensation hearings, etc. And these were all part of the scope of the standard pre-SES psychological evaluation to not only determine whether these were present singly or in combination, but also their severity, and to make judgments based upon their potential to impact the patient's ability to respond to spinal column stimulation. So this was the status quo from at least the mid-1990s until probably at least 2010 or so. And by that time, my team had become increasingly disenchanted with the value of this process and feeling as if, despite our efforts to examine the literature and look for signs of progress, that it just wasn't happening. There was sort of a static field that wasn't evolving at nearly the pace, say, that the technologies themselves were evolving. So by about 2015, we had started to formalize our process of making changes based upon what we felt like were some of the most serious deficits. And some of these that you see here. One, it took very little examination of the literature to see that all of this upfront attention did not appear to be well justified in terms of the time, the money, and the investments for the patient and even the multidisciplinary pain team themselves. And for example, looking at pain intensity changes as the primary outcome, although there were independent or single studies that might have identified some psychosocial factor as a predictor of pain intensity following SES placement in a particular sample, there were no consistent predictors. You couldn't put your finger on any one condition, any one behavior. Similarly, and this was mirrored by our own experience, despite the fact that we were frequently completing about 50 of these pre-stimulator or pre-implantable pain device evaluations per year just in my hospital, we could count typically on one hand in a given year how many of them were excluded based primarily on psychosocial factors. And that was usually a patient, say, who had some sort of undiagnosed dementia at the time, and it sort of slipped through the cracks until they had met with the psychiatrist or psychologist. So a lot of time went into these, and yet it did not appear to have very many tangible outcomes in terms of predicting outcomes or to thoroughly vetting candidates who might or might not perhaps be better suited to the type of treatment. The third item listed was perhaps my biggest concern, particularly as a clinical psychologist. When I'm working with patients who are struggling with chronic pain, I, as much as possible, want to develop an alliance with them so that they feel as if I'm a person who's bringing novel complementary strategies for helping to maximize their pain management and quality of life. And instead, the traditional model of spinal column stimulation, it puts the psychologist in the unfortunate position of being a gatekeeper. And instead of being an ally, they're often cast more as an adversary, where patients will come in knowing that it's an insurance mandated practice. They can often go to Google and look up the answers. They know what's likely to be asked about and the answers that they shouldn't provide, or at least the kinds of answers that they shouldn't provide. And so it creates a process that is often unhealthy for the patient, is less likely to find exactly the kind of information that would be pertinent to maximizing the quality of the decision for the medical team and for the patient, and doesn't promote any sort of long-term alliance between the patient and the psychologist. They're just jumping through hoops, is often the perception that they had. And we really wanted to change that. I also work in bariatric psychology, and so we'd observed actually some empirical findings from that literature showing that oftentimes these medical interventions improve mental health. And at the same time, I was working with one of my colleagues here, Dr. Chakravarthy at VA San Diego, who was working with some of our alternative SES technologies. And some of his preliminary evidence showed that mental health factors, for example, depression and anxiety, might be improved by these devices. And in that case, it sort of turned the whole paradigm on its head, because rather than arguing that comorbid psychiatric factors should in fact eliminate or raise concerns about a person being considered for spinal column stimulation, now if in fact their mental health conditions are improving, they're sort of getting two birds with one stone from the same treatment. You could almost argue that they should be put to the front of the line. And that's a 180-degree philosophical shift. And then lastly, what we felt like was contributing to kind of the dead end sense that we had for the field, that the psychology component of spinal column stimulation, implantable pain device treatments really wasn't improving. It just seemed to be static. And we felt like that was because there was no follow-up element. So there was no way to validate whether what we were doing was working or not working, whether our guesses, our clinical decision-making, our hypotheses were being supported or not supported. So it left us sort of in the dark. And that was a feeling that we were uncomfortable with, both as clinicians and as scientists. And we realized that looking around the literature, there didn't appear to be a movement for changing it on the outside. So we decided that we really needed to change it from the inside and took the responsibility for ourselves. Now, mentioned here that one of the deficits or concerns about not following up with patients to ask about more than just, say, pain intensity changes is the fact that this is a population, again, that we know is prone to a host of different psychosocial and psychiatric comorbidities. And these things can easily vacillate, worsen, change in unpredictable ways, even after perhaps a successful spinal column stimulator or implantable pain device treatment. And this just lists and highlights some of the most significant kinds of unintentional but still potential adverse outcomes that you can see among this population. And so certainly one that we saw pretty commonly, even from our early work, was that patients could sometimes report clinically meaningful improvements, such as 50% or greater improvements in pain intensity, and yet there were no measurable changes in their quality of life. They weren't going back to work, their living circumstances were the same, they appeared to have about the same level of objective functionality, and it wasn't translating in the way that we hoped. And this happened seemingly to a significant minority of cases. That there's another portion of the population that, because implantable pain devices seem to be, in most cases, most systems, an end of the road kind of treatment, that patients, not unreasonably perhaps, put a lot of stock. And this is maybe their last best shot of getting their quality of life back, their pain to improve. They've often tried everything else. So perhaps not surprisingly for some patients, if their device doesn't work out well, then this becomes something that can trigger a spiral of hopelessness and depression. The person's just kind of wanting to give up. I work at a VA, and so as you may guess, the veteran population in particular, they're at higher risk of outcomes such as unemployment and homelessness, as well as comorbid conditions such as post-traumatic stress that are less common in the non-veteran population. And then lastly, here you can see that for a subset of patients, it seems like their mental health got worse, seemingly for reasons unrelated to the spinal column stimulator in many cases. So collectively, this for us made what we felt like was a compelling legal and research or scientific case for evolving the traditional pre-stimulator psychological evaluation to a more long-term model that evaluated patients both pre and post. And these are some of the major advantages and rationale points behind this, that having a longer-term pre and post model would allow us to capture some of these adverse outcomes that occurred. And similarly, it would allow us to not only capture and identify when these adverse events occurred, but then we could connect patients to appropriate treatments. And this would not only probably improve their perhaps mental health, psychosocial circumstances, it might very well improve their pain-related function and SES specific outcomes as well. We also felt that if you could measure a person's psychosocial circumstances after their stimulator rather than before, that probably would be a better long-term predictor of their function going forward. We felt like this fed into a model that it created the kinds of relationships that we wanted as a clinic, so that we could tell patients up front that they were really joining us in a long-term partnership where we were evaluating their quality of life, their overall health, as well as their pain before. And then if they went on and got a device, got a stimulator, that we would be routinely following up with them for a year or more as well. And that this was the type of description that seemed to be well received by patients, which is very often just the opposite of how our veterans feel in more traditional medical care, where they go into a specialty clinic, they get some sort of an acute intervention, and then they're discharged from the clinic with no follow-up with the providers at all. We wanted to really provide a different kind of experience. And then lastly, related to some of our frustrations about a static field, we felt like we can do our best to put together a longer term model that includes repeated assessments. And meaning that we can do our best to include the kinds of outcomes, to measure the kinds of changes in areas of psychiatric and social function that we believed would be amenable to change. But we also recognize that there's a good chance we could be wrong, or that we could be mismeasuring things. However, simply by the act of measuring things, pre and post, we could learn about our hypotheses, and therefore we could make corrections. And so that this wasn't going to be a static model that we rolled out, but sort of a living model, an evolving model, where we used our experiences and the data that we were collecting in sort of a feedback loop to continue to improve the system. Getting a little more into the practical dimension. So what were some of our specific goals? So we had a strong rationale for improving the model, going from a pre-stimulator only to a model that included both pre-stimulator as well as post-stimulator assessments with a psychologist. And these were some of the dimensions that we felt like were important to improve in terms of our practical and theoretical goals. Just sort of starting from the top, one is that even in 2018, 2019, we were beginning as a hospital to shift to versions of remote care, starting to use telehealth technologies. So it was clear, the writing was on the wall that that was a path going forward. So whatever model we devised, it needed to be friendly with both in-person as well as remote formats. We needed to keep these visits short, particularly for the post assessments, knowing that it would be perhaps more challenging to get patients to be able to complete these visits. So we needed to make them as time efficient as possible. Thirdly, we felt like this was something that was absolutely critical. We needed to think about ways to get the patient to feel like they were partnering with us. They weren't coming in and being evaluated. They were coming in, and as part of the assessment, they were participating in an active discussion about treatment planning, where they were identifying their own goals. Of course, every patient seeking a stimulator or a pain pump wants their pain to improve. However, the specific goals that they have in terms of their function, quality of life, beyond just pain intensity reductions vary markedly. And I'll show you some slides about that later. But we wanted to just build in as a formal part of the process, patients being part of the treatment planning. We wanted to create a pre and post model that's centered around the things that we thought were most likely to change. And that meant making some hard cuts from the traditional model in terms of the content. And then lastly, beyond just mood symptoms and pain symptoms, we also wanted to be able to include dimensions of function as objective as possible in terms of physical function, attending medical appointments, medication use changes, etc. Here were some of the psychometric measures that we thought about just in terms of general dimensions. If you know anything about psychological measures, you know that some of them are longer, some of them are shorter, some of them are validated and specifically really designed for patients with certain medical conditions, whereas others are more general and mainstream. Some of them are better validated or validated for certain purposes. So we wanted to create, again, a combination that captured some of the most relevant dimensions for pain populations. So depression, substance abuse, pain and pain-related psychology symptoms, anxiety and PTSD, PTSD being, again, particularly important for a veteran population, such as the one that I work with. And then dimensions that also captured common problems among the chronic pain population, such as sleep impairment, overall physical symptom burden, isolation and social support, and more general negative affect beyond just anxiety and depression. You can see here at the bottom a link. So we designed this into a HIPAA compliant format using a survey tool called Qualtrics, where we can easily, through email, send patients an anonymous link that they can then complete. And we can securely log into the site and access their results with no names, no PHI involved at all, and then be able to use that information whether we are seeing them in person or over a video conference. This is just kind of a breakdown of our model as well as some of the contents. So our vision was that a patient could come and see us at what's called here baseline. Meaning the pre-stimulator or the pre-implantable pain device assessment and some of the dimensions involved. Again, this included psychosocial dimensions. This included chart review to obtain objective information about factors such as medication use and medication, or pardon me, treatment adherence in terms of medical visit attendance, some of their patient goals. We were initially hoping to measure walking tolerance objectively, that is, having something like a 5 or a 6 minute walk test. However, with COVID and changes to remote care, we've had to settle, at least for now, to self-reported walking tolerance. And you can see that then we repeated most all of these dimensions, with the exception of cognitive function, which we didn't anticipate to change, but that we knew was important to measure in the implantable pain device evaluation minimum, so that we can sort of chart a course and evaluate each veteran over time in terms of what dimensions are changing, what dimensions are most important to them, what dimensions might actually be getting worse, and be able to connect them with treatments as needed, short-term, long-term, and evaluating areas where the overall treatment planning might be improved by including more of an emphasis on certain areas. This way, we're sort of making it their own individual pain journey. Now, we recognize right off the bat that no matter how much theory might support a new model, there were practical barriers. And so I want to highlight several of these. That one, it was clear that patients are often told by providers that there really is no choice. You've got to see the psychologist. And even though we wanted to change our role from being a gatekeeper into more of an ally, that nevertheless, we knew that patients would have a very high rate of attendance of seeing us before their stimulator. But we were less certain about our ability to get them to come back afterwards. We knew that there would be additional resources that were both technological and perhaps even in terms of physical staffing to conduct post-SES visits. With busy clinics, it's easy to develop wait lists, even for the pre-stimulator clinic visits, for example. And so then having the time to dedicate to the post-stimulator visits as well is an extra burden for a clinic with otherwise limited resources. I already mentioned the need for remote assessment tools. And then lastly, although we were shielded from this in the VA and that we're not dependent upon insurance reimbursing us for post-stimulator or implantable pain device visits, we knew that this was a looming issue to be able to make this a case for other hospitals being able to apply as well. So let me talk briefly about each of these and sort of what we have done to minimize the degree to which they remain a barrier for us. So for us, we're planting the seed even during our pre-stimulator, pre-implantable pain device evaluation with the patient that their meeting with us is just the beginning. And not that it's intended to be a long-term difficult relationship, but a long-term more fruitful relationship where we're really getting to know them, understanding their needs, partnering with them on their pain journey, understanding some of their own unique goals, and that they're informed right off the bat that just as part of the routine process, the way that our multidisciplinary pain clinic works, if they go on and receive a device, we'll be following up with them later. And that we'll specifically be using some of the information that they share with us during the first visit to then evaluate their changes and discuss additional needs and treatments later on. Of course, then we combine that with some practical changes, such as doing most of the post-assessment visits remotely. So we're trying to minimize time, minimize burden, minimize travel, minimize cost for our patients to be able to participate in this process. And then the last point, by planting the seed early, by integrating their feedback into treatment design, we really want them to feel as if this is their pain journey and that they're sort of co-leading the efforts and they're not simply jumping through hoops, but they're participating in a teamwork process. Related to some of the resources, we knew that to make this feasible for our own clinic and certainly for others, we had to make this as easy and automatized as possible. So being able to send a Qualtrics link, do remote visits, to be able to shorten the post-SES visits often to 30 or 45 minutes, doing everything possible to minimize the time, minimize the burden for the clinic, for the clinicians, and of course for the patients. The lack of reimbursement, we really see this as a process. What we would like to do, we feel like in the VA, we're in a position of luxury in the sense that because we're not beholden to insurance reimbursement, we don't have to be limited in terms of what we do and how we do it. So if we feel like there's something that we can do to improve this process, we can go ahead and do it while collecting data so that we hope to, over time, to be able to demonstrate that this makes sense to do everywhere and that whatever additional costs and resources might be involved while working to minimize those, they are justified by the improved outcomes. We would like to, over the next 5 or 10 years, be able to continue to publish, continue to collect data, and provide an increasingly compelling case to hospital systems at large and even to the insurance companies that this is a model that's financially justified. It improves patient care and it improves outcomes. I mentioned here that, at least for our population, recognizing that these, of course, might vary somewhat from population to population, really trying to focus on the kinds of psychosocial and psychiatric factors that are most likely to change. So let's look at some data. What we see here is a few of our psychosocial dimensions. So this relates to the Pittsburgh Sleep Questionnaire Inventory, so sleep impairment. The GAD is a general anxiety disorder questionnaire, so it's an anxiety symptom measure. The PHQ-9 measures depressive symptoms, and the PHQ-15 finally measures overall physical symptom burden. And you can see that I've categorized these into levels of no symptoms, minimum, mild, moderate, and severe. So we were pleased to see that relatively small percentages of our population fell into the severe ranges. However, we did, not surprisingly, also find that a healthy minority of our populations fell into the at least moderate category. And we were surprised, even despite all of our clinical experience with the population, of just how high the rates of comorbid sleep impairment were in the population. So we had a lot of mild and moderate depression, a lot of mild and moderate anxiety, almost ubiquitous sleep impairment, and a fairly high physical symptom burden beyond just pain symptoms in our population. Looking at these same dimensions, these are some of our most recent outcome data in terms of our ability to follow up and recomplete assessments with our first couple of dozen post-stimulator cases. There might be one pain pump case in here, but these are overwhelmingly stimulators by and large. And what I've categorized here for you are based upon more detailed breakdowns of changes on these specific dimensions of more or less what percentage of them either experienced essentially no change or a very small change. And those are in the black in the middle. And then also what percentage experienced both significant decreases, or what you and I would call improvements, versus clinically significant increases. And of course, that refers to actual worsening of the condition. And this both fell in line with some of our hypotheses as well as surprised us. So on one hand, for example, if you look near the bottom, our patients reliably reported improved pain intensity and improved what's called pain disability. So these seem to correlate pretty well and to reliably improve, although of course there was still at least some minor cases where patients weren't getting better or in some very small cases getting worse. Whereas on some of the more traditional psychosocial features, such as sleep, such as anxiety, such as depression, this is where we saw a surprisingly mixed bag. And overall, the consensus was that for most patients, they weren't reporting meaningful changes at all. And then among those who were reporting clinically meaningful changes, that they were just as likely to report increases in those symptoms as they were improvements. I mentioned that as part of the process, we collect patient-centered goals. And what we've done here is categorize these for you, because you might wonder, well, when people are identifying their own goals, that is, we ask them, sort of in your own words, to identify, if you had a favorable pain outcome, what dimensions of your life would you like to see improved? And this, as you can see here, it really spans a whole range based upon people's own priorities. So being able to do physically more activity, pain reduction, those are perhaps predictably common goals. And then from there, recreation, social activities, physical and mental health, being physically independent, getting back to work, et cetera, et cetera. And we had patients identify 3 of these, often in more than one category. And what you can see here is that most of our patients, in fact, did quite well in the sense that about 20% of them achieved all 3 of the goals that they identified for us, which we felt like really was a victory. And a bit just north of 40% achieved at least 2 out of their 3 goals. So this was really meaning that almost 2/3 of the patient population was achieving either 2 out of 3 or even all 3 out of 3 of the goals that they identified, with only just a smaller minority either achieving just 1 out of 3 or no goals at all. So we were pleasantly surprised by how well that part of the assessment and follow-up process worked. Here's some data on walking tolerance. Kind of a mixed bag, even though overall you can see at the bottom that about half of the patients reported a meaningful increase in their ability to walk in terms of time or distance. But there was a significant minorities that either reported no change or even, in most cases, a slight decreased walking tolerance. This just highlights kind of the overall process. I mentioned earlier that we want this to be something that is evolving, a living process, and of course working with our multidisciplinary pain providers on the medical side. And so we're really trying to meet with patients as early on in the process as possible to be able to identify any sort of treatable barriers, such as comorbid mental health conditions, the need to get attached to mental health treatments, to be able to be connected with homeless vet programs or other kinds of social work interventions that might be necessary. We're really trying to improve their candidacy as much as possible by meeting with them as early as possible and identifying amenable or changeable barriers that they might be encountering. We do these in integrated assessment report format so that we're looking at chart reviews. We're looking, of course, at results from their validated questionnaires, and we're completing clinical interviews and really trying to combine this information and not over relying on any one of them. This is another picture of the same kind of thing in terms of sort of where we began and where we are at now. So we get more or less handoffs from our pain physician colleagues when they identify what they feel like are potential candidates. We have team discussions based on our evaluation and the physicians meeting with the patients and make team-based decisions. And then we follow with patients, short-term and long-term. The last couple of slides, I'll just sort of highlight some of the findings that were both surprisingly good as well as areas that clearly need further work and investigation on our part. And that we found, yet again, some additional supportive evidence that stimulators have reliable effects on pain intensity as well as self-reported pain disability. We also saw, for the most part, pretty consistent findings on dimensions of physical capacity in terms of walking tolerance. Our goal assessment, again, these are patient-identified goals, not goals identified by the providers, that these were achieved with a very high reliability. And that's contrast with some of our psychosocial specific symptoms. So unfortunately, based upon our objectively still limited sample to date, we can't reliably say that dimensions such as post-traumatic stress and anxiety and depression and sleep and so forth are improving, even among patients who are otherwise reporting improved pain and less pain disability. We hope in the future that as our sample size for the post-assessments grows still larger, that we are able to break down some of these results and even into different types of SCS treatment, such as the high frequency and the DRGs and some of the other kinds of stimulation treatment that might have rationales for providing different levels of effectiveness, not just on pain, but on quality of life. And then lastly, again, we're really thinking about this as kind of like a 10-year process where we're trying to achieve kind of a Kuhnian revolution, trying to change the field, trying to argue that there's a compelling rationale for doing the pain psychology evaluation component process of the implantable pain device process itself in a new and a better way. But we also know that the rationale itself needs to be supported by data. It needs to be supported by practical solutions to the barriers that arise from trying to change the mechanic from the way that it's been for more than 2 decades now. And we've encountered our own problems, and some of these we're still trying to solve ourselves in terms of being able to, say, track patients as reliably as possible, and to improve some of our measurement techniques. And some of our patients pass away, some of them change states, some of them change hospital systems. In many ways, it's like a long-term clinical trial where it's easiest to get patients in the door to begin the clinical trial and increasingly difficult as time goes from months into years of being able to follow up reliably with the population. Lastly, here, a subset of references. Of course, there are many. These are some cited in some of our own recent papers. And thank you so much for your time. I will look forward to perhaps answering some of your questions here in a few days.